Hello everyone, a warm welcome for those who have subscribed to this channel and have been loyal. This video is about introduction to hypertension, focusing on epidemiology and general considerations. Hypertension is one of the leading causes of the global burden of disease. Approximately 7.6 million deaths, 13 to 15% of the total, and 92 million disability-adjusted life years worldwide were attributable to high blood pressure in 2001. Hypertension doubles the risk of cardiovascular diseases, including coronary heart disease (CHD), congestive heart failure (CHF), ischemic and hemorrhagic stroke, renal failure, and peripheral arterial disease. Although antihypertensive therapy reduces the risks of cardiovascular and renal disease, large segments of the hypertensive population are either untreated or inadequately treated. Epidemiology: blood pressure levels, the rate of age-related increases in blood pressure, and the prevalence of hypertension vary among countries and among subpopulations within a country. Hypertension is present in all populations except for a small number of individuals living in developing countries. In industrialized societies, blood pressure increases steadily during the first 2 decades of life. In children and adolescents, blood pressure is associated with growth and maturation. In the United States, average systolic blood pressure is higher for men than for women during early adulthood, although among older individuals, the age-related rate of rise is steeper for women. Consequently, among individuals aged 60 and older, systolic blood pressures of women are higher than those of men. Among adults, diastolic blood pressure also increases progressively with age until approximately 55 years, after which it tends to decrease. The consequence is a widening of pulse pressure, the difference between systolic and diastolic blood pressure beyond age 60. Hypertension is a serious medical condition that significantly increases the risks of heart, brain, kidney, and other diseases. According to the WHO STEP survey, the prevalence of hypertension in Ethiopia is 16%. In Ethiopia and other low- and middle-income countries, there is a wide gap between evidence-based recommendations and current practice. Treatment of major CVD risk factors remains suboptimal, and only a minority of patients who are treated reach their target levels for blood pressure, blood sugar, and blood cholesterol. Measuring blood pressure is the only way to diagnose hypertension, as most people with raised blood pressure have no symptoms. Blood pressure measurements should be conducted on all patients during health facility visits as part of the vital sign. All adults are advised to check their blood pressures, but the focus will be screening all adults aged 30 years of age, as the yield off getting individuals with raised blood pressure will be higher based on the National WHO STEP survey report. Every patient with an elevated blood pressure reading requires repeated measurements to confirm the reading, and enroll into care. More frequent screening with blood pressure measurements is particularly important to rule out or rule in hypertension in adults who have had a prior heart attack or stroke, have diabetes, have chronic kidney disease (CKD), are obese, use tobacco, have a family history of heart attack or stroke. Hypertension may be primary, essential, or secondary to known diseases. Severe hypertension with end organ damage is termed emergent hypertension. It is more common and usually more severe in persons of African lineage. Environmental factors like evidence linking levels of dietary sodium intake with hypertension prevalence in population groups is impressive, although not everyone with excessive salt intake develops hypertension. The other important factor is stress, probably mediated by neurogenic vasoconstriction, is a factor in the development of hypertension. Other factors include obesity, cigarette smoking, and physical inactivity. Evidence linking levels of dietary sodium intake with hypertension prevalence in population groups is impressive, although not everyone with excessive salt intake develops hypertension. Approximately 90% to 95% of hypertension is idiopathic, so-called essential hypertension. Although the molecular pathways that regulate normal blood pressure are reasonably well understood, the causes of hypertension in most individuals remain unknown. It seems likely that hypertension is a multifactorial disorder resulting from the cumulative effects of multiple genetic polymorphisms and interacting environmental factors. A small number of patients, approximately 5%, are said to have secondary hypertension resulting from an underlying renal or adrenal disease. For example, primary aldosteronism, Cushing's syndrome, or pheochromocytoma, renal artery stenosis, or other identifiable cause. The prevalence and vulnerability to complications of hypertension increase with age and are higher among African Americans. Besides increasing atherosclerotic risk, hypertension can cause cardiac hypertrophy and heart failure, hypertensive heart disease, multi-infarct dementia, aortic dissection, and renal failure. Unfortunately, hypertension typically remains asymptomatic until late in its course, and even severely elevated pressures can be clinically silent for years. Left untreated, roughly half of hypertensive patients die of ischemic heart disease, IHD, or congestive heart failure, and another third die of stroke. Treatment with blood pressure lowering drugs dramatically reduces the incidence and death rates attributable to all forms of hypertension-related pathology. Secondary hypertension is secondary to known causes, including 1. Renal disease is by far the most common cause of secondary hypertension. Causes of renal hypertension include disorders of the renal parenchyma, unilateral renal artery stenosis can be caused by atherosclerosis or unilateral fibromuscular dysplasia. It is marked by atrophy of the affected kidney. Other mechanism of renal hypertension occurs through stimulation of the renin-angiotensin system. 1. Juxtaglomerular cells respond to decreased vascular tone by secreting renin, which facilitates the conversion of angiotensinogen to angiotensin I, which is further converted to angiotensin II. Angiotensin E promotes hypertension by acting both as a vasoconstrictor and as an activator of aldosterone secretion. Aldosteronoporous sodium and water retention. 2. Endocrine disorders like primary aldosteronism or Conn syndrome, which is usually associated with an adrenocortical adenoma or bilateral adrenal hyperplasia. In addition to hypertension, it is marked by increased serum sodium and reduced serum potassium, acromegaly, Cushing's syndrome of pituitary or adrenocortical origin, pheochromocytoma, and hyperthyroidism. C. Diabetes mellitus, when complicated by diabetic glomerulosclerosis, can cause hypertension. Other causes include coarctation of the aorta, which causes hypertension limited to the upper body CNS disorders, especially brain tumors, and drugs and chemicals, notably amphetamines and steroids. Malignant hypertension can be a complication of either essential primary or secondary hypertension. It follows an axellotad clinical course. Malignant hypertension occurs in less than 5% of patients with elevated blood pressure, most often in young African American males. Characteristic features include a marked increase in diastolic blood pressure, focal retinal hemorrhages and papilledema, left ventricular hypertrophy, and left ventricular failure. It most often results in early death from congestive heart failure, cerebrovascular accident, or renal failure. It produces the renal changes of malignant nephrosclerosis, arterioles or glomerular capillaries rupture, resulting in flea-bitten kidney, multiple pinpoint petechial hemorrhages on the kidney surface, large, swollen kidneys, necrotizing arteriolitis, and glomerulitis with fibrinoid necrosis, and hyperplastic arteriolosclerosis affecting both the glomeruli and arterioles. In general, hypertension is diagnosed on 2 visits, on different days. Systolic blood pressure on both days is greater than or equal to 140 mmHg and or diastolic blood pressure on both days is greater than or equal to 90 mmHg, the diagnosis of hypertension should be confirmed at an additional patient visit, usually 1 to 4 weeks after the first measurement, depending on the measured values and other circumstances. Classification of hypertension: Grade 1 hypertension is systolic blood pressure of 140 to 159 millimeters of mercury and or diastolic blood pressure of 90 to 99 millimeters of mercury. Grade 2 hypertension is systolic blood pressure of 160 to 179 millimeters of mercury and or diastolic blood pressure of 100 to 109 millimeters of mercury. Grade 3 severe hypertension is systolic blood pressure of greater than or equal to 180 millimeters of mercury and or diastolic blood pressure of greater than or equal to 110 millimeters of mercury. Hypertension emergency: hypertension urgency history, physical examination, laboratory, and other diagnostic tests. Recommended management will be covered in another video. Thank you for watching. Don't forget to share the video.